Okay, so thanks again for the opportunity and privilege to be able to speak to you at this very amazing multidisciplinary conference. And today I'm going to talk to you about the role of the gut, brain, and microbiome axis and how this is relevant to chronic pain. Describe the potential role of diet in the management of chronic pain. And to piggyback off the previous speaker, discuss how mind-body interventions, particularly from some of the research we recently have been doing, may be used to manage chronic pain. So as this audience is very well aware, chronic pain is a major health problem that can affect all facets of life, influencing thought, mood, and behavior. And as a gastroenterologist rather than a pain specialist, I was shocked to find that between 20 to 30% of patients or people living in Western countries are affected by chronic pain. And the current pharmaceutical therapeutic options are only partly efficacious, resulting in 30% pain reduction for only half of chronic pain patients. And as this conference has very nicely summarized, chronic pain presents multiple challenges, including the adaptative changes that occur in the nervous system with persistent pain, the concepts of neuroplasticity, and the fact that changes can occur at all levels of the pain pathway. And therefore, successful treatment may require combinations of therapies with different mechanisms of actions. I'd like to introduce you to the gut-brain axis. If you can believe, there are 10 trillion bacterial cells in our body, compared to only 1/10 of our own human DNA. Therefore, we are in fact more bacterial in composition rather than human. Therefore, understanding the gut-brain axis and its bidirectional communication between the gut and the brain and the gut in its role to maintain homeostasis is critical to understanding, to having a complete understanding about chronic disease etiopathogenesis as well as management. Now, in the next slide, I'm going to highlight to you here how the gut-brain axis may be important in managing or in contributing towards chronic pain. At the level of the colonic lumen, you'll see that there are trillions of bacterial cells that live in this very finite area. And these gut bacteria, under normal circumstances, they are responsible for maintaining gut homeostasis, which can lead towards appropriate neurohormonal signaling. When there is a concept of dysbiosis, meaning that gut microbiota are present in differing abundances and differing subtypes, these gut bacteria, when they are altered, may translate from the colon, move through the colonic wall and colonic epithelium, stimulate multiple microbiota-derived mediators, which through multiple mechanisms of signaling can influence the immune cells, the white blood cells, the nociceptor activation and sensitization of cells, mast cells, macrophages, and through these multiple mechanisms can ultimately lead towards the liberation of pro and regulatory or anti-inflammatory mediators, manage the neuronal excitability of diseases, ultimately resulting in chronic pain. Now here, I'd like to remind you that there are multiple factors that contribute towards the gut bacterial colonization and type in the colon. Now, some factors of the gut microbial composition are out of our control. And examples of these would include our genetics, as well as our modality of birth and early life feeding, so breastfeeding versus bottle feeding. However, there are multiple contributors towards the gut bacteria which are amenable to change, and diet is perhaps the most important determinant of the gut microbiota which are amenable to change. Now, microbiome-based therapies come in a few shapes and sizes, and many of you will be familiar with probiotics and prebiotic therapies, which are designed towards modulating the gut microbiome in a way that is favorable to health. At the very other extreme, fecal microbial transplantation is a specific microbiome-based transplant therapy, which has been studied in multiple infectious diseases such as C. difficile colitis, as well as inflammatory bowel disease. And transplanting fecal material from a donor into a deceased colon can be efficacious in improving outcomes, again mediated through managing colonic dysbiosis. But I'd like to highlight to you that diet perhaps is the most important determinant of the microbiome, and dietary therapies should be considered as primary gut microbiome therapies. Now, I'll say this because short-chain fatty acids, which are metabolite derivatives stemming from the gut microbial cells, and proteases, again, a metabolite or byproduct of the gut microbiome, are responsible for stimulation of important cell types, such as the enterochromaffin cells and the L cells, which can result in vagal afferent stimulation and spinal afferent stimulation, resulting in the pain experience. Now, short-chain fatty acids are fatty acids that are derived from non-digestible carbohydrates, particularly prebiotic fibers and resistant starches. In digestive health, butyrate, a specific type of the short-chain fatty acid, is critical to improve and assist with bowel inflammation improvement and enhancement of mucosal repair. It has an indirect effect on inflammatory visceral pain. Similarly, specific food products can stimulate proteases, which are important modulators of visceral pain. And proteases are released from many cell types, including mast cells, neutrophils, and enterocytes. And through its activation of the PAR receptors, can either lead to hyperexcitability of neurons or inhibition. I'd like to remind you that our dietary patterns have changed over the last 100 years. Prior to industrialization, many people would follow the so-called Prudent Diet, which is still very prevalent in non-industrialized countries. Now, the Prudent Diet is one that is rich in phytochemicals, rich in antioxidants, green leafy vegetables, fruits, and other natural sources of food, including omega-3 fatty acids, high in dietary fiber, prebiotics, and resistant starches, which can modulate the short-chain fatty acid profile, resulting in enhanced mucus secretion at the level of the gut, increased antimicrobial peptides, which nicely keep these bacteria away from the colonic wall, regulating the immune response, maintaining the intestinal barrier, and contributing towards immune homeostasis. In contrast, the well-known Western diet, which is rich in sugars, emulsifiers, which are a specific type of food additive, rich in saturated fat, and importantly, higher in meat protein, can result in toxic bile acids, branched-chain fatty acids, which are less immune friendly, resulting in enhanced mucus degradation, reduced antimicrobial peptides, bringing those bacteria very close to the colonic wall and stimulating the immune response, leading to inflammation and chronic diseases. So we see that these dietary patterns, components, and various nutrients and food additives can affect the gut microbiome through multiple different mechanisms, leading to inflammatory bowel disease, which is the focus of our research group's study, but also to many digestive diseases and arguably other chronic health disorders. So in gastrointestinal world, we see a lot of patients suffering from visceral pain or pain arising from the internal organs. And examples of IBS or functional abdominal pain would be classic examples of visceral pain. And here, preclinical studies have identified that gut microbiota, particularly in animal models, play a role in the pathogenesis of visceral pain. And when in animal studies, these animals who experience chronic pain are provided antibiotic or probiotic treatments, there is a significant improvement in their visceral hypersensitivity. In human populations, clinical studies also support the role of the gut microbiota as a promising strategy to improve visceral pain management. For example, in irritable bowel syndrome, rifaximin, which is a non-absorbable antibiotic, is very effective in improving the chronic pain in patients living with IBS. Similarly, probiotics have a role to play in improving IBS outcomes. Similarly, dietary therapies using specific therapeutic diets, such as the low FODMAP diet, which is an acronym for fermentable oligo, di, and monosaccharides and polyols, also result in improvement in pain, all mediated through the gut microbiota, suggesting that modulating the gut microbiota may improve the course of visceral pain. Now, when we think of inflammatory pain, such as that which arises in inflammatory bowel disease, there are two components of this type of pain that was nicely outlined in an earlier talk. And those include decreases in pain threshold, as well as an increase in pain response. And inflammatory pain in conditions like IBD are mediated through multiple hormones, such as the presence, upregulation of tumor necrosis factor alpha, and various interleukins and chemokines. And activation of these multiple mediators can activate or sensitize peripheral pain receptors to cause peripheral pain hypersensitivity. Here, I'd like to share that specific food items, such as carrageenan, which is a food additive seen in many milk products, was able to induce inflammation, but this inflammation was attenuated in germ-free mice. But once these germ-free mice were recolonized with normal bacteria, pain was more magnified, suggesting a role for the microbiota in the pain experience. In individuals that have interleukin-10, an anti-inflammatory cytokine deficiency, these patients tend to see greater perception of pain. Vitamin D deficiency, particularly in animal models, has been associated with mechanical allodynia and neuronal hyperexcitability, suggesting that gut microbiota targeted interventions may have promise in the management of pain. Now, I think all of you will be familiar with the Mediterranean diet, which in fact is not truly a diet, but a method of lifestyle that has been endemic to Southern Europe for several hundred years. And the Mediterranean diet is one that is rooted in higher intake of non-refined cereals and products and non-refined grain products, fruits, vegetables, olive oil, and dairy products consumed on a regular daily basis, with weekly only consumption of fish, poultry, olives, pulses, and nuts, and very infrequent use of red meat. Now, the Mediterranean diet has been translated to a Mediterranean diet score to reflect the degree of adherence to the Mediterranean diet, with greater scores indicating greater adherence to the diet and lower scores indicating less adherence to the diet. And I orient you to this grading scale to help you understand the next study. This was a very interesting study just published earlier this year in Clinical Nutrition 2020, which was a multi-center prospective study with 4-year follow-up and over 4,000 patients. Here, this study sought to identify the effect of compliance with the Mediterranean diet in patients with chronic knee osteoarthritis and knee pain for at least 30 days in the preceding 12 months, or patients were eligible to be included if they were at high risk of developing knee osteoarthritic pain due to risk factors such as obesity. Here, diet data were collected using validated food frequency questionnaires and the application of the Mediterranean diet score. And at baseline and follow-up, patients had full knee assessments, both clinical and radiographic assessments, with outcomes including symptomatic osteoarthritis, including a new onset of painful knee during the follow-up period, plus radiographic osteoarthritis evidence or worsening pain during the 4-year follow-up period. Here, I'd like to highlight to you, orient you to this, this graphic here, this table on the right. And over the 4-year follow-up, what they found here, they categorized patients into low adherence with the Mediterranean diet, so Mediterranean diet score less than 24, into 5 groups or into quintiles, whereby the highest group with adherence to the Mediterranean diet was a score greater than 32. And here, participants who had a greater adherence to the Mediterranean diet compared to those with a lower adherence to the Mediterranean diet had significantly fewer episodes of pain worsening over that 4-year window. Now, looking at a subset of those patients, so close to 3,000 patients, again, patients in the highest Mediterranean compliant group compared to those in the lowest group had fewer episodes of newer symptomatic knee onset over the 4-year period. However, when they looked at radiographic knee outcomes, so x-rays only, not clinical interpretation, they did not find any significant differences in radiographic knee changes in the highest compared to the lowest adherence to the Mediterranean diet food groupings. The authors concluded that the possible mechanisms for fewer pain and fewer new onset knee pain included greater or decreases in inflammatory parameters that could lead to destruction in knee cartilage, decreases in oxidative stress markers by improving collagen type 2 expression, and the benefit of increased dietary fiber and increased olive oil intake, which could improve articular knee cartilage, leading to improved knee outcomes. In a much smaller pilot study published a couple of years ago in Complementary Therapeutic Medicine, the investigators sought to identify the impact of a plant-based diet and its effect on chronic MSK pain. This was an 8-week longitudinal exploratory pilot cohort study designed to examine the value of a plant-based diet in the management of MSK pain. To be included in this study, patients required chronic pain defined as greater than 6 weeks and not part of another systemic process, and adult patients over the age of 18. And patients were excluded if they were already consuming a plant-based diet or other specialized diets, or were in fact found to have acute versus chronic pain. In this small study, there were 20 patients that were enrolled, and these patients received educational training describing the allowed foods, the foods that were not allowed, food substitutions, and provided with a sample menu. This diet was delivered through the study dietitian, who followed up with these patients at the study onset as well as at weekly intervals. And they defined compliance as minimum 80% adherence rate. Here at baseline, this was a clinically obese population with a BMI of 36 and mean baseline weight of 98. And at baseline, patients had moderate pain using a validated pain scale called the NPRS index. Patients also had only moderately good quality of life. After the 8-week dietary intervention, there was no significant improvement on weight or BMI. However, the pain score improved significantly from a baseline of 5.5 to a follow-up of 2.36, which was reported as clinically important. And a significant improvement was observed in overall quality of life using the short form 36. The authors concluded that the mechanisms for improved MSK pain may have been related to decreased exposures to dietary inflammatory precursors, neutralization of free radicals, and improvement in vascularization, which may have occurred due to improvement in lipid profiles. With that in mind, we recently completed a randomized control trial evaluating dietary interventions in patients with Crohn's disease. Here we included a group of patients with Crohn's disease in remission using traditional or conventional medications. We categorized patients as having either a non-diversified or a pro-inflammatory diet versus a diversified or anti-inflammatory diet. we hypothesized that patients in remission consuming a non-diversified or pro-inflammatory diet will have a significantly different gut microbiome compared to patients consuming a diversified diet. And subsequently, a structured dietary intervention to improve dietary diversity will reduce dysbiosis. A non-diversified grouping included patients that consumed less than or equal to 3 servings of fruit and vegetables per day, greater than or equal to 3 servings of red meat per week, or less than or equal to 15 grams of dietary fiber daily. If they did not meet these criteria, they were then considered to have a diversified diet. Here at baseline, we looked to see whether there was a relationship between the overall Mediterranean diet score and gut markers of inflammation using fecal calprotectin threshold of 250. We did not identify any relationship between the overall Mediterranean diet score and gut inflammation. However, similar to previous work in other conditions, we identified that there was a significant relationship between increased leafy green vegetables, increased intake of legumes, and increased intake of fish, and its protective effect on gut inflammation. High intakes of leafy greens, legumes, and fish were associated with lower fecal calprotectin thresholds. If we looked at a more rigorous cutoff of gut inflammation using a fecal calprotectin of less than 100, we found that leafy green intake was strongly associated with lower markers of gut inflammation. And if we looked at dietary relationships to systemic markers of inflammation, such as a C-reactive protein, we found that C-reactive protein less than or equal to 5 was significantly related to an omega-6 to omega-3 ratio of 8 to 1, whereas common Western diets would have a ratio ranging between 20 to 25 to 1. Looking at the effects of these dietary groupings on microbiome, we identified that a diversified diet compared to a non-diversified diet was associated with very significant gut microbiome markers at baseline. In particular, patients with a non-diversified or pro-inflammatory grouping had greater proteobacteria phyla, which is thought to have more inflammatory potential, and greater Escherichia and Shigella compared to the diversified group at baseline. Again, these are thought to be more pathogenic organisms. But after a follow-up intervention for 8 weeks, we found that these differences between groupings actually disappeared, suggesting that the microbiome is alterable or can respond favorably to a structured dietary intervention. Looking at the relationship between various foods and its relationship to cytokines, we found some interesting trends as well. For example, processed meat intake was strongly associated with interferon gamma, which is a pro-inflammatory cytokine. Beta carotenes, for example, from carrots and from leafy green vegetables and other root vegetables was strongly associated with interleukin 10, which is an anti-inflammatory or regulatory cytokines. When we look at various food groupings, we see that they also were strongly either positively or inversely correlated to various bacterial subtypes, suggesting that dietary components can be a powerful therapy in modulating inflammation. Now, with that in mind, I'd like to switch over to an entirely different focus of the presentation. And the rationale for this is that I feel that chronic pain and chronic disease management really requires a significant integrated approach to overall care. And as a lifestyle intervention researcher, I think a holistic approach to this is really more powerful than an individual or reductionistic approach that we tend to do in mainstream medical practice. Now, the previous speaker nicely summarized this slide very beautifully, and certainly I won't be able to do thousands of years of history justice within the next couple of minutes. But I'd like to orient you to the fact that yoga is a mind-body intervention which has powerful implications in overall health and well-being. And typically it involves three major practices as it applies to modern day practice. And these would include physical postures, which Western societies are very familiar with, breath control, and meditation. And yoga has been adapted as a method used in complementary and alternative medicine for past several decades, and it has been used very successfully in the prevention and therapy of diseases. And it is gaining popularity as a therapeutic practice in North America, with close to 10% of the US population having engaged in yoga for health-related reasons. And its role in chronic pain management was nicely summarized by the previous speaker. Now, I'd like to highlight here that the various hierarchy of pain signaling is very important in understanding how and where yoga might fit into its therapeutic potential. So pain is first signaled and transmitted through the nociceptive primary afferents at the level of the pain source. Then this pain signaling is terminated in the dorsal horn of the spinal cord. Secondary order neurons then travel through the spinal thalamic tract and end at the brain centers, particularly the anterior cingulate cortex, the limbic system, and the somatosensory cortex. And it's at the level of the brain that the pain signal is interpreted and then contextualized and attached to an emotional response, such as fear, anxiety, or depression. And it's at this level of the brain that complementary alternative medicine therapies, such as yoga and meditation, are likely to have its greatest effects. Similarly, other cognitive therapies, such as cognitive behavioral therapies, hypnosis, and others may have its primary mechanism of action at this level. This slide I found very interesting because it highlights the various therapies that are outlined and that can be used for the management of chronic pain that addresses these various other aspects of the pain pathway. So an integrated approach to this pain pathway can be very instrumental in having an overall salutary benefit for the patient. Now, my interest in yoga really comes from its application in digestive health. And yoga as a primary therapy is in fact accepted as primary therapies in multiple GI disorders. This was a very nice study published a couple of years ago in APT, reporting on the beneficial effects of yoga in the treatment of ulcerative colitis. This was a single-blind, single-center, randomized control trial in patients with ulcerative colitis who were in remission. To be included in this study, patients were required to have an impaired quality of life with a low quality of life score using the IBD-Q. And patients were randomly allocated to either yoga or written self-care. And the yoga practice included 90 minutes of traditional hatha yoga group sessions over 12 weeks, together with inner involvement, whereas the self-care group included 2 evidence-based self-care books providing general information on UC and general resources on self-help groups. And although this is a busy slide, I'd like to highlight to you some very important findings that in the yoga group compared to the self-health group at week 12, which was the primary endpoint of the study, patients that participated or were randomized to the yoga group had significantly improved outcomes on physical quality of life, mental quality of life, anxiety, depression, and perceived stress. Now, at the 24 weeks. These patients were followed out to 24 weeks, even though there was no prescribed intervention in those 12 weeks after the study completion. And remarkably, these positive mental health effects were sustained out to week 24. And patients continued to practice these interventions on their own at home without any specific guidance because they found the effects to be so great at week 12. So the authors concluded that this 12-week yoga intervention significantly induced clinically relevant improvements in quality of life, mental health, and stress-related outcomes. And finally, I'd like to share that we recently completed a very small 8-week pilot study looking at yoga in patients with inflammatory bowel disease. In 13 patients who participated in the study, they were taught specific postures, specific breathing techniques, Om chanting, a very powerful meditation chanting strategy, and guided meditation. They were encouraged daily practice at home. And at baseline, 100% of patients speculated that the main advantage of yoga would be on improved mental health and relaxation, with the majority of participants identifying that they would also see an improvement in physical fitness. 2/3 of patients reported possible disadvantages to be for time allocation for daily practice. And following the 8-week intervention, all of these positive attitudes did not change. Importantly, in terms of harder outcomes, there was a trend towards improvement in anxiety, significant improvements in depression, as well as improvements in mental health quality of life. In this study, we did not see any significant improvements on perceived stress. However, this may have been due to our small sample size, as well as due to reasonably low stress levels at baseline. So I'd like to just highlight, we've translated our diet and yoga-based programming, and we have a physical activity programming to a digital health mobile application called LifeMD, which is designed to help the patient become the healthiest, happiest person that they can be using lifestyle evidence-based programming in chronic digestive diseases. In the interest of time, I won't run through these slides with you, but these are just an example of some of the slides involved in our mobile application. For now, the build is in Crohn's disease, ulcerative colitis, non-alcoholic fatty liver disease, and we also have baseline preventative health programming for improvement in gut microbiome as well as inflammation-based outcomes. And we also have introduced a yoga, breathing, and mindfulness plan to help improve patients with regards to their sleep outcomes, their stress outcomes, and overall well-being, and similarly an introduction to physical activity. So with that, I'd like to conclude that the evidence is growing for the use of lifestyle-based therapies in the management of pain, and that integrating dietary solutions and mind-body interventions to conventional pain management may provide opportunities to target multiple areas of the pain pathway to improve outcomes. Thanks again for the wonderful opportunity to speak to you today.